Okay, so first of all, I would like to thank the IBCA Foundation for inviting me to come here all the way from Brazil to give this talk today. And now changing a little bit more the subject from invasive to non-invasive, and also from neurology and rehabilitation to clinical psychiatry. And as a psychiatrist, my first goal would be to convince you that the psychiatric disorders are the most important. But fortunately, so these are my disclosures, but fortunately I do not have to convince you that psychiatric disorders are the most important, because the data are pretty convincing. So if we measure disability in terms of years lived with disability, which is a method for estimating the burden of the disease, we can see that almost one out of 4 years lived of disability are caused by either mental disorders or substance use disorders. And when we consider only the non-communicable diseases, that means excluding injuries or excluding infectious disease, for instance, then up to 1/3 of the burden of all diseases and disorders are caused by mental and substance use disorders. Examining the conditions, we can see that major depressive disorder is it's the most important cause of disability. We can also see that schizophrenia is an important cause, OCD is also an important cause, substance use disorders are also important causes of disability. And in terms of regions that mental diseases are spread out, I would say that they are pretty democratic. So we can see that mental disorders occur in developing countries, in America, in Europe, in Africa, and Asia. So basically we have mental disorders everywhere in the world. It's an important topic regardless where you are. Another important topic when we talk about mental disorder is that the available treatments are pretty limited in terms of efficacy. So we have numbers, for instance, that up to 1/3 of patients do not respond well when treating depression. This number goes up to 40% in schizophrenia and up to 60% in drug addiction. So this, of course, highlights the need of development of novel strategies, and non-invasive brain stimulation are such techniques. Just to give an overall view, we have the invasive techniques. In psychiatry, we also use vagus nerve stimulation and deep brain stimulation. Of course, this is much more embryonary nowadays. We have ECT, which is an old established technique, and we have the non-invasive brain stimulation techniques, as Professor Ramon told us. We have TMS, and we have Tdcs, transcranial electric stimulation, which is in fact not a technique, but a group of techniques, and I'm going to discuss today DC, direct current stimulation. So just to give a very basic overview, we do not know completely the mechanisms of action of TDCS, so there are big discussions in this issue, but TDCS is basically a neuromodulatory technique where we inject a weak 1 to 2 milliamp current using electrodes placed over the head. And it's known for more than 50 years that when we do direct current stimulation in the animal brain, then there are cortical excitability changes, as we can see here. But only recently, in the last 15 years, that we know that when we do transcranial direct current stimulation, we are also able to induce motor cortical excitability changes. And the classic findings is that anodal stimulation increases cortical excitability, cathodal stimulation decreases cortical excitability. We know that this is not true for all cases, but this is the framework we use nowadays, even in psychiatry, for instance. And why there is such an interest in TDCS? Because of several characteristics of TDCS, some of them Professor Hum told us. For instance, it's an affordable technique. It's basically a battery, 2 electrodes that we place over the head, and then we induce electric current. It's also portable, so here I'm showing one device which is pretty big actually. So there are nowadays devices of the size of an iPhone, for instance. So portability is a very important good characteristic of TDCS. It's also easy to learn, so it's not restricted to physicians or to researchers, but also patients and caregivers can use and learn how to use TDCS. It also has low maintenance costs. It also has a low rate of adverse effects. So adverse effects, the most common adverse effects are itching, tingling, headache, burning, and discomfort. All of them are mostly mild and well tolerated in most cases. And it's also considered a safe technique. So we do not have many animal data, but the animal data we have show us that the threshold for inducing brain lesions is at least 50 times higher than the intensity that we use to treat patients in clinical practice. So it's pretty safe when we do this comparison with animal studies. And so just to introduce to you depression, many of you know about the characteristics of the disorder, but depression is characterized by two main symptoms, which are the depressive mood and anhedonia, which is the lack of interest and lack of pleasure to do things. And also there are many accessory symptoms of the disorder, such as anxiety, pain, changes in appetite, changes in sleep. So it's a pretty complex disorder if we consider all these characteristics. We do not know exactly the mechanisms of action of non-invasive brain stimulation. In fact, we do not know even the mechanisms of antidepressant drugs to treat depression. So we know even less about TDCS and TMS as a treatment for depression. But the framework that we use is that depression is associated with a hypoactivity in the prefrontal cortex and a hyperactivity in subcortical regions. So we use TDCS, for instance, to increase cortical activity, or TMS to increase cortical activity in certain areas, such as the prefrontal cortex, and by top-down modulation, the subcortical activity is decreased, and then this interplay between cortical areas and subcortical areas are restored, and then this is accompanied by an improvement in depressive symptoms. So this framework also explains, for instance, the mechanisms of TMS and also the mechanisms of antidepressant drugs, and DBS, which would first decrease subcortical activity and then increase cortical activity. So nowadays we have about 10 randomized clinical trials. So initially there were open label studies. Now we have randomized clinical trials using TDCS in depression. We can see that over time the sample size increased. Always the anode, which increases cortical stability, is placed over the left dorsolateral prefrontal cortex. The cathode is placed either on the right supraorbital area or the right dorsolateral prefrontal cortex. There was a trend over time to increase the intensity of the current. So in the beginning we were using 1 milliamp, now we are using 2 milliamps, and also there is a trend for increasing the number of sessions. So early studies did 1 session every other day for a total of 5 sessions, and now we are doing 10 to 15 sessions once a day, excluding weekends, so 3 weeks of treatment. There are some meta-analyses of individual patient data. There are some meta-analyses, and one of them is a meta-analysis of individual patient data that we did. So we collect data from 6 centers, 6 studies in 5 centers in Canada, Australia, France, Germany, and Brazil. We had a total of almost 300 patients, and we found in this individual patient data meta-analysis that response rates were about 34% in the active versus less than 20% in the sham group. Also in terms of remission, TDCS was more effective than sham, and the numbers that we found in this meta-analysis are comparable to the efficacy of TMS or the efficacy of antidepressant drugs. Of course, we have to remember that we are talking here about a number of less than 300. For TMS, we have approximately 3,000 patients from randomized clinical trials, and the SSRIs, antidepressant drugs, for instance, we have more than 10,000. So we have to keep in mind that the scale of the evidence is different, but anyway, promising results for TDCS in depression. One of the studies that we did was this Factorial Design, where we compared the efficacy of sertraline, which is an antidepressant drug, and TDCS. So we recruited 120 patients with depression. They were not using antidepressant drugs at baseline, so this would be an important confounding factor that that we were able to control. They were suffering from unipolar depression of at least moderate to severe intensity. A factorial design is also known as a 2x2 design, which means that we had 4 arms. So in one arm, we had just placebo. You can see here the first arm, only placebo, shunt Tdcs plus placebo. The other arm, we had sertraline. The other arm, we had Tdcs, and the other arm, we had combined treatment. So for double-blinded reasons, patients receive both Tdcs and the pill. However, the Tdcs could be either sham or active, and also the pill could be placebo pill or could be sertraline. Sertraline was used in a dose of 50 milligrams per day, and we did a total of 12 Tdcs sessions, initially 10 sessions in the first 2 weeks, and then 1 session every other week until week 6, which was our end point. We used a 2 milliamp current intensity, and we did stimulation for 30 minutes per day. Those were our results. So we can see here that the combined treatment, which is in black, there was an early improvement. So as early as 2 weeks of treatment, this combined therapy group was superior to all other groups. And we can also see that at endpoint, at week 6, this combined therapy group also achieved greater depression improvement compared to the other groups. We can also see here in the green line that Tdcs as a monotherapy was more effective than placebo and as effective as sertraline, but this only at week 6, only at endpoint, and not during or not after 2 weeks of treatment, which is interesting. The effects of Tdcs alone was delayed, so not immediately after the acute treatment phase, but only 4 weeks after that. When we consider response and remission rates, which are more hard outcomes, more clinically meaningful outcomes, we also found that the combined treatment produced response rates, which is a good improvement in clinical terms of 63%, and a remission rate, which in clinical terms is a almost complete improvement of depression of almost 50%. So the results were pretty good. Also, as a monotherapy, Tdcs achieved response and remission rates of approximately 40%. So we also tested the efficacy of Tdcs in other types of depression. One study that we have just finished was using Tdcs for treating post-stroke depression. So, as you know, post-stroke depression is a common complication of stroke. Patients who have post-stroke depression have a greater morbidity and also greater mortality. And then the issue of side effects of pharmacotherapy is even more important in post-stroke depression because these patients also have autonomic dysfunctions, and they are also using other pharmacological therapies. So this was our flow chart in this study. And we also found that active Tdcs was more effective than sham. We used the same design of doing initially 10 sessions and then 1 session every other week. Interestingly, we found the same issue of not immediate effects of Tdcs. So during the first 10 days of treatment, there was no difference whatsoever between active and sham, but the effects were only evident at endpoint at week 6. In this case, we can see that we found very low response and remission rates in post-stroke depression. This might have been caused by the more biological nature of post-stroke depression when compared to unipolar depression, but the response and remission rates of Tdcs were the same as we found in unipolar depression or in meta-analysis. We are now exploring the issue of whether Tdcs could substitute antidepressant drugs in clinical practice, because in our early trial we compared Tdcs against a low dose of sertraline, only 50 milligrams per day. It's a pretty low dose in the treatment of depression. Now we are using a full dose of 20 milligrams per day of escitalopram, which is a first-line treatment of depression. And now our goal is to prove non-inferiority, which means that Tdcs would be non-inferior to escitalopram. We also have a placebo arm because if we found, for instance, similar effects, we would not know if both therapies were good or bad. Then that's why we need the placebo arm to prove that. And we are not only interested in the clinical outcomes, but also to understand a little bit more how Tdcs works in depression and how the effects of Tdcs and escitalopram differ. And that's why we are also collecting several predictors of response, such as neuroimaging, genetics, and many others. The evidence of Tdcs as a treatment of bipolar depression is currently very low. There is only one non-controlled trial that it was done in Italy in 2011 with 31 patients, 17 with major depression and 14 with bipolar depression. 10 sessions over 5 days, so twice a day sessions were done, and then it was found similar improvement in both groups. But of course, this was an open trial, the quality of evidence is low. We are also doing a randomized clinical trial in bipolar depression. We want to recruit 60 patients and using the same design as I showed you before, and also our aim here is twofold: one, to prove clinical efficacy, and the second is to understand better the mechanisms of action of Tdcs in bipolar depression. There are issues when we think about using Tdcs in treating depression. One is how to use this therapy as a maintenance treatment. So, for instance, when we use antidepressant drugs, this is pretty easy. We just the patient, for instance, gets better when using antidepressant drug, and then this drug is maintained over 6 months, 12 months, 2 years. But how can we do this with Tdcs? We do like 4 weeks of treatment, but can we keep doing Tdcs once a day for months or years? We try to address this question, initially doing Tdcs every other week in the maintenance treatment phase. So our patients who responded to Tdcs received this therapy of every other week for 6 months, and we found a relapse rate of 50% after 6 months, which was high, and showing that we need to develop better ways to use Tdcs as a maintenance treatment. And as Professor Hummel told us, one good alternative for Tdcs is to use home-based Tdcs devices. The technology already exists. It's very simple. We just have to find the optimal way to give Tdcs to these patients and to teach them how to use Tdcs correctly, and then they could use, for instance, every day or every other day for a longer period of time. So I showed you a little bit about depression, but Tdcs has been used for other disorders as well. One of them is schizophrenia. Schizophrenia is also a complex disorder. It has positive symptoms such as delusions and auditory hallucination. It also presents negative symptoms. It also presents disorganization. So it's a complex groups of symptoms occurring in schizophrenia. An initial trial was done by Jérôme Brunoni in 2012, where they were specifically interested in targeting auditory hallucinations in patients with schizophrenia, which is an important symptom in schizophrenia. It's a positive symptom. And in order to treat these auditory hallucinations, they placed the cathode electrode, which decreases cortical stability, over the left temporal parietal junction, which is an area associated with auditory hallucinations. They also placed the anode over the left dorsolateral prefrontal cortex, because this is also an area associated with negative symptoms. This was not their primary goal to treat negative symptoms, but they used this montage to take advantages of the polarity-dependent effects of Tdcs. In this trial was relatively small. They used 30 patients using 2 milliamps intensity, 20 minutes, and 10 sessions twice a day for 5 consecutive days. And then they found that active Tdcs was superior to sham immediately after Tdcs, but what's very interesting in this study is that they did only 10 sessions of Tdcs in 1 week, and the effects were sustained for up to 3 months. So perhaps indicating in schizophrenia, differently than in depression, that TDCS is somehow able to induce long-lasting effects. They also examined other symptoms of schizophrenia, and they also found a trend for improving other types of symptoms, such as negative symptoms as well. Okay, sorry for that. And just to, I'm almost finishing, just to show the last disorders. So another randomized clinical trial where TDCS was used to treat patients with alcohol dependence. This was also a small phase 2 trial recruiting 35 patients who also received only 5 sessions of TDCS, and then they were followed up for 6 months. So alcohol dependence issue is the relapse rates over a longer period of time. So you have to follow up these patients for at least 6 months, which was done in this study. And the authors found superiority of active TDCS versus sham. The effect size was very small, marginally significant, a P of 0.02, but indicating a possible efficacy of TDCS also for alcohol dependence. Thinking about using brain stimulation in psychiatry, we could think that neurostimulation techniques could be used in different levels of care. And now it's a reality, for instance, to use ECT in clinical practice and also to use TMS in clinical practice. But both therapies have issues. ECT needs sedation, it has a high cost, it has some prejudice against it, and so we use more in refractory patients. TMS is established therapy, but it has a reasonable cost, and also patients need to go to the clinical center every day, and so therefore we could think as TDCS as something that we could use as a first-line therapy in primary care, because TDCS has a low cost, it's easy to use, it's possible to use at home, and it's also possible to combine with pharmacotherapy to enhance its efficacy. And finally, to conclude, TDCS is an interesting alternative for the treatment of psychiatric disorders because it combines characteristics such as ease of use, low cost, portability, and no serious adverse effects. For depression, there is some evidence for TDCS efficacy, although we need more confirmatory trials. For other psychiatric disorders, we have some initial positive results. However, we should further explore in further clinical trials. Just to finish, I would like to thank my staff that did most of this work, and also thank you for the audience. Thank you.